brilliant, amiable, gentle human being whom we lost at a very early age. We are joined today by faculty and students of our department, radiologists from eminent hospitals across the country, members of the ISMRM, parents and friends of Anoop. We extend a very warm welcome to all of you this evening and thank you for taking out your time to join us in this endeavor. I'll now request Krishna to say a few words about Anoop.
Dr. Anoop was a wonderful person, an efficient resident and loved by all. He was the ideal student and inspiration to his juniors. His sincerity in clinical work, enthusiastic case presentations, and empathy towards patients were exemplary. Equally talented in sports, he always managed to find time for football and cricket. Born and raised in Kasaragod, Kerala, he graduated from Calicut Medical College and completed his radiology residency with us at AIIMS between 2012 and 2014. His hard work earned him the prestigious Dr. Shyam Sharma Gold Medal for the best radiology postgraduate of the year 2015. It broke our hearts when Dr. Anoop's journey was cruelly cut short on the 28th of August 2020 after a valiant battle against leukemia. Although fate stole him from him too soon, Dr. Anoop will forever be a part of the AIIMS radiology family. Today, on his 37th birth anniversary, we come together once again to honor his memory. I would now like to invite Professor Raju Sharma to introduce the speaker for the 4th Dr. Anoop Memorial Lecture.
Thanks, Krishna. We are honored to have with us today Dr. Vikas Gulani, orator for the evening, and it is my proud privilege to introduce him. He's professor and chair of the Department of Radiology at University of Michigan, Ann Arbor, a large department with over 100 faculty members. A luminary in the field of MR imaging, Dr. Gulani has incomparable expertise in abdominal imaging. This engineer turned physician is truly a brilliant personality. Along with a bachelor's in engineering from UCLA, followed by a master's from Illinois, he also has a PhD in physiology to his credit before he went on to train as a physician. How anyone can compress all that in one lifetime never ceases to amaze me. His background in physics and engineering inspired him to dabble in the technology arena of imaging, which has resulted in pioneering work in the field of MR fingerprinting, the topic of today's oration. On a lighter note, when I asked him to share his CV for this event, he said, in the interest of brevity, it can be summed up in one sentence. Vikas spends most of his time answering emails, but when not doing so, he is lost somewhere between the reading room and the lab. To add perspective, however, his CV is a voluminous saga of phenomenal achievements, awards, and honors. The humble person that Vikas is, he would much prefer the brief bio instead. The floor is all yours, Vikas.
Dr. Vikas, please unmute yourself.
Happens once a day. It has to happen at the most public forum possible. Thank you so much. I cannot possibly do justice to that kind introduction, but I will give it my best. And it is truly an honor to be invited to AIIMS to speak at this lecture in honor of Dr. Anoop. So first and foremost, thank you all for having me. And secondly, to the memory and to the family of Dr. Anoop, I wish I had known him when he was with you, but I hope to do him justice today. I get research support from Siemens Healthineers on MR fingerprinting and low field imaging, and I have intellectual property patents that have been licensed by Siemens. This is a rough outline of where we're going to go. I won't spend too much time on this because I have, as always, too many slides for this occasion. If you look at the goals of radiological imaging, it can be summed up in 2 lines, which is to diagnose, follow up, and treat disease using anatomical images. And minimal invasiveness is a principle of our field. Now, at the same time, this is what happens in real life. This is a biopsy that I did, and I was very proud of having accomplished it, but this is not good for the patient. This needle is between the aorta and IVC trying to sample some lymph nodes. And the reason for this is that actually we're pretty uncertain. And when we're uncertain, we have to go and get biopsy proof of what we're doing. I would argue, and I have argued in almost every talk I've ever given, that every biopsy is an imaging failure. and that there is no exception to this. I think that we as an imaging community should really be thinking about how to get rid of tissue diagnosis to be able to make the diagnosis on the basis of pictures alone. Now consider these two images, one on the left and one on the right. They're both T2-weighted images, and they look wildly different. Now, you might laugh and say, well, yes, one's a single shot T2-weighted, the other is an MRCP, but what about these two? These two images are from two different vendors in a prostate, and the white arrow points to a cancer, the yellow arrow points to prostatitis, the orange arrow points to normal prostatic tissue. Look at how wildly different they look on these two images, and these are two vendors. The patient is imaged less than a month apart. So in the meanwhile, while you have this kind of heterogeneity, we as an imaging community and as a physician community want to move towards precision medicine. And our goals need to be definitive diagnosis and personalized monitoring and tailoring of the imaging protocols. I would argue to you that in order to do this, we have to move from purely anatomical imaging towards something that provides numbers that we can rely on, so we can be more objective in how we're evaluating the disease process. Now, what do we measure in imaging? Well, we mostly measure size. And I've put this ruler up as a little bit of a joke because Roy Philly, who was a famous radiologist at UCSF, he's credited with saying a radiologist with a ruler is a radiologist in trouble. So is that really true, however? Could we move towards definitive answers? Could we move towards objective measurement of what we want to assess? And could we quantify our certainty or our uncertainty? That's also useful. Oops. When you look at MRI, it's sensitive to a whole lot of properties. And in theory, any of these could be measured. And in fact, many of these are. If you look at some examples of quantitative MRI, diffusion MRI is used quite often in stroke and cancer, MR elastography with liver stiffness, fat quantification, and NASH and NAFLD, ideal and QSM for iron deposition, and on and on and on. So there are examples of quantitative MRI in our field. And but why are numbers so hard to get in MRI? We don't fundamentally measure our core properties, T1 and T2. This whole project, this whole work started back in the day when I was a medical student. I started to ask myself, where's my Hounsfield unit? When I look at CT, there's a Hounsfield unit. Why don't I have one in MRI? And this was seen as kind of almost an impertinent question to the person I asked it to. But I, as a medical student who was used to being in the lab before that, was genuinely confused. Why don't I have a Hounsfield unit? So the answer to this is, of course, that MRI is slow. And let me explain why. So on the top, you have a video that shows the excitation process, and the spins that we image are shown as a gray magnet, and the red magnet is the RF pulse that we apply. Now, once we tip the magnetization over into the XY plane, we measure the signal. And this is the transverse plane that we tip the magnetization over into. And this measured signal decays away very quickly. And this, of course, is characterized by T2. And during this presence of the signal, we can measure the signal. Once the signal is gone, we have to repeat the process. And repeating the process is governed by the longitudinal relaxation, T1 relaxation, which takes a long time. So our signal decays away very quickly, but it comes back very slowly. And this governs the speed of MRI, right? So how can we get around this? But before that, we must also recognize that the longitudinal and transverse relaxation are providing physiological information about our tissue. And if we could measure them, we'd have a window into tissue that we didn't have before. So let's say that we want to measure T2. Now, here are two tissues with longer and shorter T2s, and we collect images along this T2 decay, and we go ahead and quantify the decay process and get a T2 measurement. Now, if you get 5 images, you have 5 images worth of imaging time that you've spent. So inherently, measuring T2 is slower than getting a T2 weighted image. But we want to measure things. And back in 2003, when I was a postdoc in physics at the University of Würzburg, I started working with Mark Griswold, who was also there. And we started with a sequence sensitive to T1 and T2. And this is inversion recovery, balanced SSFP, or inversion recovery true FISP, however you wish to call it. But the beautiful thing about the sequence is that it's sensitive to both T1 and T2. And we wanted to go faster. So we started measuring T1 and T2 with this sequence, and we kept making it faster and faster over several years. Over almost 6 or 7 years, we kept working on this process. And this is really the predecessor paper to the fingerprinting paper. And in this, we quantified T1, T2 very quickly, and we were getting, using a golden angle radial approach, which is not important for the discussion here, but we were going about as fast as we could. And even if we could get an image in, say, 8 milliseconds, what we found were that there were a set of problems that we were encountering. So if you were looking at the fast recovering part of an inversion recovery curve, that contains lots of information, right? And the flat part of the curve contains very little information. However, when we sample these curves, we have a lot more data points, very easy to collect information about the flat part of the curve, and very difficult to collect information about the fast part of the curve. So you could keep collecting forever, it doesn't help you. However, if your sampling density is even slightly too low, now you have a problem, because you have no way of distinguishing the dashed curve from the solid curve. And so not only are we slow at this point, but we're also inaccurate. And this is a huge problem. Now, at the same time, there was a paper from Maria Donieva, who works for Philips, and this was a very influential paper in our thinking. And what she said was that the MR signal is described by just a few parameters. And this information content is small and compressible. And if you think about it, it's a zero crossing, it's the T2, it's the signal evolution. It's very few pieces of information that actually go into quantifying the curve. So what she did was she randomly undersampled the images. Look at the kinds of images that she got. They're very poor quality, but she calculated a dictionary of expected signal time courses in, say, a T2 weighted or a T1 weighted set of images. And she asked which curve from the dictionary most closely matches the observed signal in each pixel. And she used an algorithm called orthogonal matching pursuit, and she came up with really nice looking maps based on this process. And this is more work from that paper. And this paper really got us thinking quite a lot. And those two sets of thinking together came into magnetic resonance fingerprinting. So recall that this is our problem, that we have an inaccurate curve, an inaccurate sampling of the fast recovering part of the curve and insufficient sampling, and we have oversampling of the flat part of the curve. So we said, why do we ever want to be in the flat part of the curve? We should get rid of that. And this became our principle, that why not have a curve that looks like this, which is always living in the fast recovering part of the curve. Now, this becomes a problem because it can't be modeled with a simple equation like a T2 curve or a T1 curve. But what if we could do something like this? Now, what we decided to do was, instead of actually measuring the curve with physics, i.e. plotting each point and fitting a curve to it, what we decided to do was a different approach. So we said, well, we know the set of physical properties that exist, that are possible for any tissue. And we know what sequence parameters we played out, the flip angles, the preparatory modules, the recovery time, and so on. So, and we know the basic physics of every sequence. So we take the physical properties, feed that into a simulation, take the sequence parameters, feed that into a simulation, and we come up with a dictionary of all possible curve evolutions. And so the kinds of images that you get are something like this. They are nothing we would ever use to diagnose disease, but they involve a signal evolution through each pixel. And this signal evolution can be modeled. And this, instead of trying to model it and fit it as a curve, we'll match the signal evolution we got in real life against the dictionary that we generated that are all possible curves. So the signal itself can be very noisy, like you see here, that's shown in blue, but it matches to the pattern from the dictionary that we wanted. Okay. And so how does this work in real life? So consider T1 and T2 and consider 4 different signal possibilities. So this is our dictionary that we're generating, right? And this is the image that we're generating in the grid. So let's say that the first voxel in the grid matches to this blue curve, which is the top curve. And then in the T1 and T2 maps, or sorry, in the third curve, in the T1 and T2 maps, you get the light orange and the light blue patterns. The second curve matches into the second pixel, and we get the dark orange and the dark blue signal. And the third curve and the fourth curve, and so on. So every time you get a match, you assign that T1 and T2 value to your map. And you continue this until you get a map that you're interested in. So this got repeated. And when you're all done with this process, pixel by pixel, you end up with T1s and T2s that look like maps. And the reason is that you're able to look through the noise and match your dictionary quite properly. The other thing is that your overall spatial encoding occurs over the entire time course. So while no one image is particularly good at showing you the anatomy, all the images together, because they're noisy, but the noise is random, they're capable of showing you the full anatomy of the picture. Now, in all of this, we made several philosophical decisions. We are after numerical tissue characterization. We don't care about anatomy alone. The entire experiment is designed around measurement. So recall that we are not getting individual images that look beautiful. The overall maps look beautiful, but the individual images look pretty bad. We're after a high information time course, i.e. we're always living in the fast evolving part of the curve, and we will tolerate low quality underlying images. And this can be extended then to abdominal imaging. And in this case, you have to extend out your work a little bit more, because in addition to T1, T2, and the various parameters you play out, you also have to measure your B1, your transmitted radio frequency pulses, because that becomes important in the body. It's not as important in the brain. But you can get really good quality abdominal fingerprinting results. There are really great contributions to this field that are not made by our group. Dr. Martijn Kloos, who was at NYU when he did this, he was doing MR fingerprinting in the presence of metallic hardware, and he had a different approach to doing B1 and B0 mapping. And you can also start to do some really interesting work here, MR fingerprinting for the rapid quantification of myocardial T1 and T2. Now, you have a beating heart. How in the world do you model your T1 and T2 in that situation? Well, it turns out you have to model the movement along with it, and you have to have a dictionary that adopts to the heartbeat. And so he's done this work, and he's also done a lot of really great work on figuring out what are the confounding factors for robust T1, T2 mapping. But this is the kind of maps that you end up with in cardiac imaging, and these maps are obtained in 5 heartbeats. And Jesse has Jesse and Nicole have a lot of work showing the beating heart with the fingerprinting maps going along with it. And on and on and on. I could not do the entire field justice. So, and a really important point of all of this is that once you're into quantitative imaging, is the performance same day to day? Is the performance same scanner to scanner, site to site? And who guarantees this? So this variability in measurements becomes a really important issue. And I think anyone who's doing quantitative imaging is obligated to publish work on this. This is not work that will get you a lot of attention, but it is really critical work in order to do this right. So we need to consider test, retest, repeatability, which is the same day repeatability. We need to consider 1 week repeatability, intra-subject variability, inter-subject, i.e. what's the biological variation that you're measuring. And you have to consider differences in phantom versus in vivo. So we started on this almost right away. This is work from Yun Jiang, who's now an assistant professor at University of Michigan with us. And he measured the repeatability of various known quantities of T1 and T2 in the ISMRM NIST Phantom. So the ISMRM, you may be familiar with. NIST is the National Institute of Standards and Technology, which defines units of measurement. For example, the second is defined by NIST, the meter is defined by NIST in the United States, and so on. So they gave us a phantom of known T1s and T2s, and then we can use it to measure our repeatability and reproducibility. We also have published a lot of work on repeatability and reproducibility in human subjects, because that is a different kind of repeatability and reproducibility. So showing it to you in breast, human brain, in prostate, and so on. So this is a lot of work that we've had to do in order to do this right. All right. So, and this is a little bit of trench warfare because it requires you to go through prostate, cardiac, abdomen, breast, brain, and every time you come up with a new sequence, you're obligated to do this all over again.
Right.
Yes. Sorry. Another need, an open need, is multi-vendor development and testing. And Guido Buoncontri, who was at PISA at that time, basically repeated our sequence in the brain on a GE scanner, and he used almost the same spirals as we did, and he showed a multi-site repeatability, reproducibility of fingerprinting at 1.5T and 3T. Proud to say the numbers were very, very similar between GE and Siemens when he implemented the exact same sequence. So what are the clinical possibilities that opens up? And I think that's the key topic now. Now, how do you use this? So consider normal tissue in blue and diseases in light green and dark green. So if you look at first glance at these tissues, there's actually a fair bit of overlap between the error bars, between the blue and the light green, and then the light green and the dark green. So if these are two disease states, there's a fair bit of overlap here. And then there's normal versus the less disease state that also has overlap. But if you look at the top bars, you start to be able to tell, well, okay, if it's above the top dashed red bar, it falls into blue. And if it is below the yellow line, it falls into a disease state. And if it's below the second yellow line, it falls into the more serious disease state. So this is also work that you have to do in order to tell these tissues apart into the various categories. And again, you have to repeat it in all these different kinds of tissue. So I'm going to focus here on prostate as an example. So we started with a sequence and we switched. Our initial work was using a IR true FISP, but FISP itself is also T1 and T2 sensitive. And this is the sequence that we've been using ever since. And we published a set of papers starting with an initial paper showing a combined fingerprinting and diffusion examination for prostate cancer. And then we went into targeted biopsy validation of these things. And Ananya Panda, who trained at Ames, was our key driver in the latter part of this work. Now, in the prostate, we want to answer a few questions. Oops. Can we distinguish cancer from not cancer? Can we become better at evaluating the transition zone, which is a difficult part of our clinical work? Transition zone is a challenging area to read. And can we identify which cancer is or is not clinically significant? Finally, we're interested in asking, can we aid with PIRADS 3 lesions? So this is our initial paper in radiology that was led by Alice Yu, who was a medical student at that time, showing that you can combine T1, T2, and diffusion from standard measurements to get to clinically important distinguishing of different kinds of tissue. Now, why did we use ADC? Because in real life, we know ADC is important. So why would we ignore this? So I think it's really important to set the use of these technologies together and not just use fingerprinting in isolation. So this was the work that Alice produced. Open circles are low-grade cancer, and dark circles are high-grade cancer. And when we include all lesions, i.e. validated only by 12-core pathology, 12-core tissue sampling, we had a hard time telling apart low grade from high and intermediate grade. But once we started using targeted biopsies, there was a tantalizing possibility that low grade cancer and high grade or intermediate grade cancer start to differentiate from one another. And all of that is different from normal peripheral. So we then moved to targeted biopsy validation, starting first with the peripheral zone. And in the peripheral zone, this got me into starting to do the biopsies myself in bore. Why? Because standard trust biopsy has a lot of pitfalls, and I didn't trust it. You could miss cancer. You could sample a part of the cancer that is not the highest grade part of the cancer. And some parts of the cancer may be difficult to reach, particularly at the apex or posteriorly or at the base of the gland. So I started to do these biopsies myself. And you start to be able to validate this work. And this is showing a cancer that we're sampling, and the cancer by T1, T2 maps in the middle, the cancer by T2 weighted and ADC map at the top. And being able to tell cancer from normal tissue is one thing, but intermediate and high-grade cancer, and by intermediate and high-grade here, I mean Gleason 3+4 or higher, i.e. grade group 2 or higher cancer, versus low-grade cancer, which we're defining as Gleason 3+3, which equals 6, or grade group 1 cancer. And what we found was that with a very high AUC, T2 and ADC combined can tell apart intermediate and high-grade cancer versus low-grade cancer in the peripheral zone. And so in the peripheral zone with the targeted biopsies, this is a little bit of a busy slide, but it's worth looking at. So in the blue triangles, you see clinically significant cancers. In the orange squares, you see low-grade cancer. And in red dots, you see prostatitis. So these lesions have been identified on T2 weighted imaging, and we've done this quantitative mapping. And what you find is that if you live in this top right square, everything here is either prostatitis or low-grade cancer. It opens up the possibility that could we reduce biopsies in this group of patients. Now we move to the transition zone. And again, this work was led by Ananya Panda. And she showed that, again, in the T1, T2, and ADC spheres, you get differentiation from normal transition zone and prostate cancer. And so this is a very important finding. And T2 plus ADC gives you nearly perfect separation between normal transition zone and prostate cancer. But what about all prostate cancers versus non-cancers, i.e. if you take a lesion that is suspicious for cancer, can you start to tell it apart based on T1, T2, and ADC? And what she found was another very tantalizing possibility. T1 and ADC combined give you very high separation between prostate cancer and non-cancers. So this starts to reach the kind of goals that I have, which is to reduce the need for biopsies. And in real life, we don't live in statistics. We live in, each individual patient we need to be able to make some decisions on. So here are two possible separation lines, depending on sensitivity and specificity that you want, but which separate out based on ADC and T1, normal transition zone and non-cancers and prostate cancers. Another tantalizing possibility that existed in that paper is being able to take the PIRADS3 PIRADS3 lesions and being able to separate them into a high risk and low risk group. Now, PIRADS3 lesions, statistically, only 20% of them are cancer. So you need a very large number of cancers in order to be able to, large number of lesions in order to be able to do this study. We didn't publish this work because we only had 6 actual cancers, and the blue dots are non-cancers. So we didn't publish it because we didn't trust it yet. But the possibility exists to be able to separate PIRADS3 lesions, and this is part of the work that we need to do in the future. Now, as a side of this, I mentioned that I started doing my own prostate biopsy. And so we ended up publishing on our experience of doing in-bore prostate biopsy. And it's a great problem-solving tool for the urologist. By the time I was all done with this project, I could have really, truly just joined the Department of Urology and done this for them for the rest of my life, and they would have been happy to have me. Because when they can't tell apart, when there's a discordance between the MR read and the biopsy result, they need to have a better way of sampling the tissue other than just MR ultrasound fusion. And this solves the need beautifully. All right, so where do we go next in prostate? Some problems that still exist. Our work was low res. It was 1 by 1 by 5 millimeters. And we cannot use this for lesion detection or easily correlate to T2 weighted imaging. It's still slow. It took us about 7 minutes to cover the whole gland. So we need to, my target is 5 minutes for the whole gland at 1 by 1 by 1 coverage, so we could reconstruct our maps in any plane we want, and moreover get the weighted images from that map. We need multi-site evaluation, and I put re-evaluation because we actually did do multi-site evaluation of our 1 by 1 by 5, but as soon as we go to high res, we need to do that all over again. So now this is work at University of Michigan. This is led by Jesus Fajardo and Yun Jiang, and they're both doing this work on high resolution 3D MR fingerprinting for prostate, and this will be equally applicable to rectal cancer and many other pelvic tissues. So this is hot off the presses. I literally had them mail me this last night. This is still at 16 minutes acquisition, but we've already got it accelerated to 8 minutes just by cutting down the length of the spirals. And this is 3D fingerprinting in axial, coronal, and sagittal planes, all at 1 by 1 by 1. This is not zero filled. So this you could reconstruct to 0.5 by 0.5 by 0.5 if you wanted. And this is also MR fingerprinting, but this is now at 0.55 Tesla to be able to make this accessible at a low cost all over the world. This is another goal of mine. And so this is 0.55 T fingerprinting. And here are synthesized or calculated T1 weighted, T2 weighted, and clinical images. And my goal, again, is that if you can get the maps at very high resolution, you should be able to reconstruct those images and match the clinical format. And this is calculated using formulas for T1 and T2, but you can imagine that if you use deep learning, you could probably construct the T2 weighted images very close to the bottom row using this approach. And because I became interested in image-guided biopsy, this is work now ongoing at 0.55 T, And Tejinder Kaur, also of your institution, and I wanted to highlight her work, is going to be leading the paper on this work. This is a patient. His PSA plotted over the course of 5 years. And over the course of these 5 years, he's also had 4 biopsies with either very low grade and low volume disease or negative biopsy. But his PSA keeps going up. It was over 25. Clearly something is discordant. And he has a hip replacement. So this is, at the top is his MR in 2019, then 21, then 23. Hip replacement at 3T plays a role. But so he came to me for biopsy. And the first thing I noticed was that at the anterior, at the posterior, where the lesion was supposed to be, there doesn't look like there's much. But anterior, in the transition zone and at the junction with the peripheral zone, there does seem to be something more worrisome. And so I started by sampling that lesion, and that showed intermediate grade cancer, 3 + 4 = 7. And we did sample his originally identified area of concern, and that turned out to be nothing, HGPIN. So we've had a lot of success with this. We've done now 5 biopsies at 0.55 T. But the reason I want to emphasize it here is that what we need to work on, the first 3 items, optimization of lesion conspicuity, optimization of imaging time, and sequence selection, all will be driven by MRF-driven design. That is, that if we can measure T1 and T2 of those tissues, we can design a sequence that is ideal for that tissue. The last bit I want to focus on is outside of prostate. And I want to share with you this work on quantitative breast imaging, because it is telling about a whole nother direction that we need to go in. So in breast fingerprinting, we can identify the tumor, and we can measure the tumor T1 and T2. The question we asked is, can we measure response to treatment? So here we have people who were given chemotherapy, neoadjuvant chemotherapy, and we have non-responders to that chemotherapy, and we have responders. And you can see that the T1 and T2 of the responders change dramatically but immediately after the chemotherapy is given and before multiple cycles of chemotherapy. So it holds out the possibility that we should be able to, by imaging, do a measurement that tells apart responders from not responders without having to give them multiple cycles of chemotherapy, which has obvious advantages in the management of these patients. And if you stop and think about it, the size of a tumor changing is a very slow process. It can take months, but the physiology of the tumor should be changing almost immediately after it responds to a drug. So this makes logical sense for us to be thinking this way. All right. And this is the last slide that actually shows a design of a sequence that is T1 weighted. So in frame E, you have a T1 weighted sequence that is designed with the tumor T1 in mind, and you are able to see the tumor on T1 weighted sequences. And this goes to my point that you should be able to design sequences that are individually targeted towards showing the tumor. It's very early work, but it shows where you can go. Finally, I want to ask if we could improve dimensionality. We have T1, we have T2. I've already shown the improvement of dimensionality by using ADC at the same time. What about perfusion, fat and water, oxygenation, stiffness, CEST and MT, and on and on and on? Could you combine a whole lot of MR parameters and really improve the characterization of tissue? What about non-MR properties? You have PET with many agents, CT, molecular imaging agents, genetic markers. You have circulating biomarkers and proteomics, and on and on and on. And there's no reason why those can't be combined with our MR to produce a better differentiation of tissues. And I think that's where the field really needs to go and will flower. There are many outstanding issues still with MR fingerprinting. You can read these for yourself. I don't need to go over them all one by one. I think my point being that it takes, every time you come up with a new way of doing things, you open up new possibilities that opens up new areas of research and advancement of human health. You know, AI in this is another interesting piece, because this cartoon ends with AI takeover of the human race. And right before that is the end of the human radiologist. This is the most sarcastic view that you can take of our field. And I would argue that all of this work points to the end of the dinosaur radiologist, one who does not respond to evolution of technology. The AI takeover can help the human race. In India right now, we have so many people who are not getting sufficient healthcare because we simply don't have enough resources to provide that healthcare to all people. Could we use the kind of quantitative information that we're producing to and use computers to analyze that information to help take care of those people? Now, that information still has to be interpreted at the end by a radiologist, but could it make it more efficient? This was a picture I took while driving through Delhi a couple of years ago, pre-pandemic, and the House of Diagnostics. And I just love this picture because this is only possible in India, right next to a pub, I think. But could we build a house of personalized diagnostics that is built on radiology and pathology and clinical input with computing to connect these pillars and really produce results for our patients? So there are many outstanding needs in quantitative MR. Phantom and normative studies are really important. I think it's really important that people publish their numbers, because if they're not publishing their numbers, they're not willing to be tested on whether those numbers are right or wrong. And I think that's an illness that is pervasive in this field, and it needs to go. And if you're a reviewer reviewing those papers, if people are not sharing their numbers, reject the paper. Repeatability and reproducibility are critical pillars of this work. Inter-site, intra-site, inter-vendor harmonization is needed. Then on the clinical side, you need robust exams. You need practical and actionable cutoffs that our radiologists can use. You need to tie our measurements to pathology and translational studies. You need to take a technology. It's not good enough to have a paper. You need to move it to patient care. And so you need multi-site large end studies, which is something I'm working to do in the future. And you need to be able to monitor treatment and response, and you need to eventually measure outcomes, society level effects, cost effectiveness, etc. This is a timeline I want to share with the young people in this audience for the development of my thinking. When I was a student at University of Illinois in 1999-2000, and I was sitting in a reading room, and the radiologist said dark on T1 and high on T2. I said, what is that? It doesn't make sense. And I was rebuked because it was felt that I was kind of making fun of him, and I wasn't. I was truly confused. I said, there's no T1 and T2 map here. In 2001 and 2, as a resident at Michigan, I started to ask myself, where is my Hounsfield unit? 2003, as a postdoc in Würzburg, shouldn't we be measuring T1 and T2? And Mark Griswold came along and really jump-started this work. And then as a resident fellow, overconfidence. Sure, no problem, we can do this, easy peasy. And then as a junior faculty at Case Western, increasingly disillusioned that this is hard. We were failing a lot. We submitted grants that weren't working. And then in 2011 through 3, we started to taste some success. Wait, we may have something. And then from 2013 to present, how do we use this? Well, so there's a long, long path from 1999 to 2023. And fingerprinting is an example of how much work it takes to slowly succeed. It's a 20+ year overnight success. Now, my PhD advisor said that problems worth solving prove their worth by fighting back. I think I encourage everyone in this audience, especially the young people, to find some problems worth solving and really put your mind to it. You're the best of what India has to offer. You can solve those problems. I want to thank my colleagues at multiple institutions who have helped me and our funding agencies. Now, I also want to thank you for having me, and I want to get rid of uncertainty in our field. I'm open to questions.
Thank you, Dr. Gulani, for doing this oration for us. It was indeed very insightful presentation. I am Sanjay Sharma, one of the attending radiologists here, and along with my co-moderator, Dr. Ashu, we are very grateful. And as you said, this technique did show a lot of promise. So, Ashu, if you're happy, we can open the questions from the attendees. Hello?
Yes.
Yeah, this
Yes,
is Dr. Deva. We have showed examples of measuring, parametric maps of T1 and T2. Is it possible, since you are matching with a dictionary thing, can we create maps of diffusion, elastogram, or any other sequence? Since you know the tissue, what the tissue is, can we
Yes.
extrapolate on, and develop or create other parametric maps apart from T1 and T2?
Yes. So this is a very insightful question, and I thank you for this question. And in theory, you should be able to measure just about anything that you're interested in. Now, the size of the dictionary goes exponentially with the number of parameters you're trying to measure. So T1, if you have T1 and T2, then you have 2 times the number of possible tissues, and the signal evolution has T1, the number of T1 points and the number of T2 points that you're interested in multiplied by one another as the possible dictionary entries. If you have 3 entries, then it becomes, let's say, T1, T2, ADC, then you get T1 times T2 times ADC number of points. So the dictionaries get much more complex, and your certainty in matches can be more complicated. Dan Ma at Case Western has published a T1, T2 ADC measurement in the brain. I do think that it should be possible to combine multiple parameters that you're interested in. I think it's important in those situations to be smart about which parameters are you doing. So, for example, in a combined exam for prostate, I would do T1, T2 ADC. In the liver, I might do T1, T2 fat fraction. And so those are the kinds of things. In fact, we are measuring T1, T2 fat fraction in the abdomen now at the University of Michigan.
Okay, so every time for each a sequence, we need to have a match in the dictionary. That's what is.
Yeah, so for each sequence you generate, you have to generate a dictionary that goes along with every possible time course in that dictionary. So imagine you have T1 and T2, and then you know exactly what you did with the sequence, or T1, T2, let's say fat fraction. You know exactly what you did in that sequence. Now, that has to be modeled out for every combination of T1 and T2 and put into a dictionary entry, right? Each entry is one possible combination of those two.
Okay, we are, by doing this matching with the dictionary, we are not actually finding out what the material is in that pixel area, or we are not doing that.
No, we are measuring, we're getting a readout at the end of T1 and T2, or whatever the quantities are that you're interested in measuring.
Okay. Thank you.
Dr. Gulani, I wanted to ask you, something very fundamental. Of all the exciting applications that you showed us, so are there any specific hardware and software requirements? Like, can we do it straight away on our platform, Siemens or Philips?
So in we have shown fingerprinting even on very old scanners. We've shown fingerprinting on the 0.55T, which is a low performance scanner. You can design sequences to run on any scanner, but when you design a sequence, it has to be runnable on that scanner. So for example, our fingerprinting sequence, we designed on 3T scanners at the Siemens platform. And the spiral acquisition that we designed is a special spiral that we actually, like, we designed that spiral case-space trajectory. We put that on the scanner, and that's what we're using. So that has to be transferred over to the scanner. We're working with Siemens now to create a more general framework that can be applied to most scanners. And that's one of my goals. You know, the answer to your question is a little bit complicated. Yes, you can do it on any scanner, but it's not trivial. Someone has to design a sequence and put it on that scanner.
Great. Thank you.
Good evening, sir. I have a question.
Yes.
So just like you showed that, so we can have quantitative numbers regarding the T1 signal, T2 signal, ADC and fat fraction. So what about the contrast dynamics? So are all these numbers in MR fingerprinting only applicable to the non-contrast acquisition? Because then it would mean like relying only on the non-contrast. So the contrast dynamics have not come into the play. So is there any idea that even the contrast dynamics may be synthetically created using the similar concept?
I think this is a great question. So, you know, there are 24 hours in a day, and we haven't had the chance to explore what the T1 change I mean, you'd expect a T1 change and probably a T2 change post-contrast. So we haven't done that work. It's low-lying fruit, actually, what is the T1 change and T2 change post-contrast in various tissues. And at the very least, you should be able to do that pre and post-contrast and get away from our headache of constantly having to subtract images in order to tell if something is enhancing. And so, you know, we should be able to measure T1, T2 post-contrast and pre-contrast and get us use it just like a Hounsfield unit, which is one of my original questions. And in CT, could use it in MR that way. Now, regarding model, you know, a more advanced part of this is I have done a fair bit of work back in the day on dynamic contrast enhanced imaging and measuring perfusion that way. You should be able to, we've done a dictionary-based approach for modeling liver perfusion. One of my lab members at Case Western did that. And that was getting very close to a fingerprinting kind of approach. So a fingerprinting approach ought to be possible for DCE imaging. And it remains to be seen whether it is more efficient or not than a standard approach for DCE imaging. I think that's another, you know, set of experiments that needs to be done that we haven't done yet. So it's open fodder for someone out there to pick up and do. I just haven't had a chance to do this. I mean, you know, the thing that you find in this field is that it's like you're in a bubble, and you're pushing this bubble out in different directions, right? And this bubble is your knowledge. So you start with your knowledge that was very small, and you pushed it out a little bit. And that's where I feel like we are. We pushed it out a little bit beyond where we were in, say, 2003. And but it opens up the possibility that you could, and each time you push it out, the bubble gets bigger. Your knowledge it's exponentially bigger when you push it out. So I think that the question you're asking, Ankur, really takes us out, that can we push this out farther into the realm of knowledge where we can use this clinically. I think that measuring post-contrast changes is one such area. We must do that because currently the state in MR is that we don't know if something is enhancing, and we struggle with it on a day-to-day basis all the time. You know, think about your renal masses. that we're sitting there. Is this thing enhancing or not? Is this subtraction really showing something or not? I mean, it's a common headache, right? So I think we could solve it this way. The second part of that is that hold on to your common headaches because those are where we should be doing the research. We should be asking clinical questions that help us improve technology.
Thank you, sir.
Hello, Dr. Gulani. I'm Dr. Chandan. I'm here. I'm a professor in radiology here. Can you hear me?
Yes.
So just have a simple 2-3 questions. Why do you call it a fingerprinting? What was the basic idea? Why you gave the name the fingerprinting?
Yeah. So, if you recall, we made a philosophical decision to live in the fast evolving part of the curve. And this came about because Mark Griswold and I wrote a grant on quantitative imaging using traditional inversion recovery TrueFist, but with a radial acquisition. And the grant was rejected without discussion. And then that was in 2009. And I rewrote that grant 3 times. And one of my mentors had said to me that you're wasting your time on this field and it's not going to succeed. And I nevertheless felt like this is something I believe in. So I rewrote that grant 3 times. And each time we didn't send in the grant. And the reason we didn't send in the grant was because it was not, our heart wasn't in it. We didn't believe that this was really solving the problem. So after the 3rd time I wrote that grant, I went to Mark's office, Mark Griswold's office, and I slammed the door and I said some things that I will not print. And I said, we need to do better than this. And I said that fundamentally the physics is against us, that we're not living in, we have this curve evolution and we can sample it forever, but we can't sample it fast enough. We were doing 8 milliseconds for each radial spoke that we were doing, and we were getting a view shared image. And it was still not fast enough to get the zero crossing, which is absolutely essential in quantifying a curve. And so I said, we can't fool physics and we're living in a problem. And so Mark said, you're right. And then he went home that weekend and he did a simulation of a T1, T2, and in gray matter, white matter, and CSF. And he came back. So it was a 3x3 grid. And he came back and he showed in a noiseless situation that you could simulate the sequence and the sequence would match every time the T1, T2 ADs, T1 and T2 for these 3 tissues and separate them out. And it was a Monday, and when he came back with this, and he had randomized the acquisition, because he said, why live in, if we want to be in the fast evolving part of the curve, we should just live in the fast evolving part of the curve. Then it poses the physics problem. And you can't just fit that curve, but you have to match that curve. So when he came to me that Monday, my mind was blown. It's like, this is going to work. And when my mind was blown, I said, you're fingerprinting the MR signal. Because if each signal evolution is a fingerprint, it's like a dictionary match. I said, you're fingerprinting the MR signal. And so I would credit Mark with coming up with the fundamental randomization of these signal evolutions. I'll take the credit for the name.
Many congratulations for that. So near future, if we put a whole body inside the MR gantry and use a aquarium MR fingerprint, keep the data, then it will be possible to regenerate the data once for a T1 map, T2 map, a DC map, or diffusion weighted like map in the near future.
I'm sorry, I didn't understand the question.
So as you have manufactured all those images, so now you have acquired the data and then can you do all those the data by post-processing? That means in the near future.
So it is post-processing. So you're getting these, what you're doing is that you select the sequence and you make the sequence sensitive to the parameters you're interested in. So it's T1, T2, ADC, fat fraction, whatever you want. Once the sequence is sensitive to those, you generate all the possible time courses that are possible with that sequence with a combination of those of the parameters. So for each T1, T2, ADC, let's say, you will generate a new curve. Then the second T1, T2, ADC, then third and fourth and so on. So the dictionary will have thousands, if not hundreds of thousands of entries. Then the map comes out, the maps come out, there are T1, T2, ADC, and whatever else you're interested in. So that is post-processing from the collected images.
So you
Makes
give
sense?
you give a quantitative report also?
I think in the future I would like to. I would like to. And actually, a related project that I'm working on is not with even MR right now. What I'm thinking about is mining the data from the electronic medical record and pulling out relevant parameters for a report. So let's say that if you're looking at prostate, you'd want to know family history, you want to know past history of cancer, you would want to know if they've been biopsied before, and so on. So that you'd want to know their PSA. So we pull that information, PSA velocity, let's say, and put that into a nomogram and put a pre-test probability for a cancer. Not only does that help us, but it helps the urologist assess that patient. And that should be in the report. So I'm working on a project like that. We're starting with bladder cancer in CT. What we're finding is that if you pull that information from EMR and combine it with, let's say, radiomics or something like that, your output on the radiomics improves. So, which makes intuitive sense to us as radiologists. We don't interpret images without the clinical information in hand, right? So could we make it easier for you to pull that clinical information? First of all, have the computer pull it. Secondly, combine it with what's known about pre-test probabilities, and then put that into the report. And I think that should be in the reports, and we're working on it.
I'm sure there are many more questions after that very stimulating talk, but I think we have to let Vikas go. He has a busy day ahead of him. It's early morning for him, and he has many tasks to achieve in the rest of the day. So I'm going to request my colleague, Dr. Ashu Bhalla, to please propose a vote of thanks.
And Dr. Vikas, thanks so much. And my comment is more philosophical that, you just at least help us put more positivity and faith into the future of what our modalities are going to deliver. And we are really thankful for the time and effort that you put into this. And you said, you should be able to throw biopsies out. I'm at least looking forward to throw some modalities out, in the sense that everything should not require an FDG PET CT. And that's what I'm really looking forward to, because for us, that is across the fence. They are not part of the same ecosystem. So at least I'm looking forward to that. It's been really such a pleasure and so exciting, that the specialty has so much more to look forward to. And thanks to everybody who has joined us on our Zoom platform. You mentioned our Sterling students. So several of them are joined in to listen to you today on the Zoom platform, as well as on the YouTube channel. And thanks again. It was indeed a very exciting 1 hour. Thank you and have a good day.
And if technology works, we would just like to present a virtual token of appreciation on behalf of the department. Deva, please go ahead. Thank you once again, Vikas, for doing this for us.
Thank you so much for having me, and thank you to the family of Dr. Anoop for joining. And this is really in his memory.
With that, we'll close this session.